Yes, thank you for that question. So, what really motivates us to continue to do research in these cancers is that we still don't cure all patients. So, patients with advanced genitourinary cancers, including kidney cancer, prostate, bladder cancer, and other cancers, they're not curable in the vast majority of metastatic advanced disease. So this is what motivates us is one day we want to be able to cure most patients, maybe all patients. That can be like a dream, but I think that that's where we want to go is to uh, cure most patients and all patients if we can, which will need us to do more research to understand the tumor biology, mechanisms of resistance. And this is where we are going. It is, and this motivates us. There is a lot of research going on from various groups, including our group here at Dana-Farber. There is research going on trying to study the renal cell carcinoma cells at a single cell level, and also to study the tumor microenvironment using novel platforms of genomic and molecular gene expression profiling, and also to study metabolomics, to study metabolites in the tumor microenvironment that might lead to resistance, that can lead to tumor growth. Um, as you may know, that Dana-Farber is also the home to a recent Nobel laureate, Dr. Bill Kalin, who has been a pioneer in studying the von Hippel-Lindau gene and the downstream hypoxia-inducible factor as drivers of tumor growth. So we have a lot of work going on in this field to try to target all these new drivers of growth of this cancer and the mechanisms of resistance. So we still have a lot to learn. It is a challenging disease. So renal cell carcinoma is a disease which we know we have known for a while that it is driven by angiogenesis. And also now we know that the immune microenvironment has a big role in driving the growth of this cancer and causing resistance. And based on these understandings, we have made progress with angiogenesis inhibitors, VEGF inhibitors, and also with the immune checkpoint inhibitors, like PD-1, PD-L1 inhibitors, and CTLA-4 inhibitors. And the combinations of these drugs have improved outcomes, and we think we're also curing more patients with these combinations. But we still don't cure all patients, like I said before. So there are still challenges to understand what other drivers of this disease lead to resistance. For example, 2 decades ago, chemotherapy had been tried for many years before that, and we have known that chemotherapy is not very active in this disease. So with the better understanding of the role of VEGF angiogenesis and the immune microenvironment, we have made progress by incorporating VEGF inhibitors and immune checkpoint inhibitors in the treatment of this disease. So basically, this is an example of where understanding the disease led to improvements. So now we have to understand the next steps of what else is driving the growth of this disease. And so there are challenges. We know that this is a heterogeneous disease. There are many drivers of resistance and growth. The role recently of resistance mechanisms, including the drivers of growth, the HIF2 alpha has emerged, which has led to an advance, perhaps with a drug called belzutifan, a HIF2 alpha inhibitor. And so this is yet another example of trying to understand this disease, which will lead to new therapy advances, which will lead to benefit in at least some groups of patients. So we have to try and keep advancing these new therapies, and at the same time developing biomarkers for what will lead to benefit with specific new drugs. So there is still a long way to go because of the heterogeneity of the disease It is not a single disease. There are many groups within this disease with different molecules driving the growth and resistance of each of these groups. Right. So you can think about the current research in terms of clinical trials and preclinical research and translational research. In terms of clinical trials, we have made recent progress with adjuvant pembrolizumab PD-1 inhibitor that improved the disease-free survival of patients with high-risk clear cell renal cell carcinoma after surgery. So that is an advance. We are looking at combinations in the first-line metastatic disease setting. As we know, VEGF plus PD-1 inhibition has led to advances. PD-1 plus CTLA-4 double immune checkpoint inhibitor combination has led to advances and improvement in the first-line therapy. So now we have to go to the next step. So the next step is perhaps more potent combinations. So there is a trial looking at the combination of ipilimumab, nivolumab, plus cabozantinib, so double immune checkpoint inhibition plus VEGF inhibition. There are other trials looking at the combination of the HIF inhibitor belzutifan with first-line VEGF plus PD-1. So that is like a triplet combination. So I think that these combinations will bring the next step of advances. Might be also a role for reinstitution of the immune checkpoint inhibitor in patients who have progressed before on immune checkpoint inhibitor. So basically reinstituting PD-1 inhibitor and combined with a VEGF inhibitor. So these strategies are being looked at as late salvage therapy, for example, cabozantinib, atezolizumab, tivozanib, nivolumab. So these kinds of combinations are being looked at. So I think that there is a role for looking at new drugs, and there are lots of phase 1 studies going on. Metabolism in inhibitors. We have had some setbacks. A glutaminase inhibitor did not improve outcomes, unfortunately, when combined with cabozantinib. But there is still a role to continue to look at whether other metabolism pathways are involved in resistance. In terms of translational and preclinical research, there is a lot of research going on to understand the tumor cell as well as the tumor microenvironment. There are also host factors which might be involved in driving resistance. For example, the way a drug is metabolized can actually lead to differences in the activity of a drug and lead to resistance. So there is a lot going on in terms of understanding the biology of the disease. I think the future will be continued basic and translational research to understand the biology of this disease, what other immune checkpoints are causing resistance. For example, LAG3, TIM3, there are many other immune checkpoints that are being looked at. There is also a better understanding of other immune cell types like the myeloid-derived suppressor cells, MDSCs, which we know are also involved in resistance. The macrophages in the tumor microenvironment can cause resistance by driving angiogenesis. So there is a better understanding of this. There are checkpoints on the macrophages, for example, the TREM1, TREM2 receptors. So there is a better understanding of biology. So once we understand this biology and figure out what other molecules could be driving resistance, I think there will be a development of newer and newer therapies, which can then be tested in clinical trials as single agent, but also in combination. Of course, when we develop these combinations, we have to be careful to develop tolerable combinations. You do not want very toxic regimens. So we have to do all this carefully and use the principles of precision medicine. So I think that the future is bright, and we have made a lot of advances over the past 5 or 6 years with the advent of immune checkpoint inhibitors. So I think that the future is bright. I think that this journal is on the right track. There is not a specific journal devoted to resistance to therapy. So that is, I think, a nice area to focus on. And one of the things I would say is I have learned that this journal is made some good progress over the past few years and is also PubMed indexed. And I think that one of the things I would suggest is, in addition to the articles, a good illustration with figures as well as accompanying pieces of video format discussions and talks would be very useful to the reader and the physicians and other providers of care to patients out there, because sometimes it is difficult, as you know, to sit down and read a whole article. So I think that capturing the message with the video format would be very, very useful with the speakers and authors.